Welcome to our monthly webinar series hosted by the Office of Integrated Healthcare Research and Policy in the Department of Family Medicine at the University of Colorado School of Medicine. Let me begin by telling you a bit about our sponsor and partners. This webinar series is sponsored by the California Mental Health Services Authority Integrated Behavioral Health Project. CalMESA is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by CalMESA are funded by counties through the voter-approved Proposition 63, the Mental Health Services Act. Prop 63 provides the funding and framework needed to expand mental health services to previously underserved populations in all of California's diverse communities. The Agency for Healthcare Research and Quality for Integrating Behavioral Health and Primary Care functions as a coordinating center and national resource for people committed to delivering comprehensive integrated healthcare. The Academy focuses on integrating behavioral healthcare into primary care practices and promotes a collaborative environment that fosters dialogue among leaders and other stakeholders in integrating behavioral health and primary care. Key Academy tasks include the National Integration Academy Council, an expert panel of nationally recognized leaders in integrated healthcare, the Academy web portal and literature repository, and the recently developed lexicon for behavioral health and primary care integration, and much more. The Collaborative Family Healthcare Association is a nonprofit, member-driven, collaborative organization in existence since 1995. CFHA promotes a comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individuals and families, patient providers, and communities. Advancing Care Together, a project at UC-Denver Department of Family Medicine, is a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program is funded by the Colorado Health Foundation and has funded 11 demonstration projects that have been organized as a set of diverse comparative case studies and will be linked to support cross-project learning. Before introducing Dr. Patrick Corrigan, I'd like to go over a few housekeeping items for GoToWebinar. On the right hand of your computer screen, you should be able to hear the audio by selecting either the microphone and speaker for your computer or by calling into the telephone. And throughout the presentation, you can submit questions to the chat feature. We'll have about 15 minutes at the end for questions and answers. And so to do this, you just type in the text area and hit submit. I'd also like to note that the webinar is being recorded and will be posted to the YouTube channel. And the YouTube channel is on your screen right here. Today we are pleased to bring you Dr. Patrick Corrigan. Dr. Corrigan is a distinguished professor of psychology at the Illinois Institute of Technology. Prior to that, he was a professor of psychiatry and the executive director of the Center for Psychiatric Rehabilitation at the University of Chicago. He is a licensed clinical psychologist providing services for people with serious mental illnesses and their families for more than 30 years. He has been principal investigator of federally funded studies on rehabilitation and consumer-operated services. 12 years ago, he became the principal investigator of the Chicago Consortium for Stigma Research, the only NIMH-funded research center examining the stigma of mental illness. The Chicago Consortium involved into the National Consortium on Stigma Empowerment, the NCSE, also supported by the NIMH. Central to the NCSE is the Center for Adherence and Self-Determination, supported as a developing center in services research by the NIMH. Located at Illinois Institute of Technology, the center includes co-principal investigators from Yale, the University of Pennsylvania, Temple, and Rutgers. In 2013, Dr. Corrigan took the helm of the NIH-funded grant on peer navigators meant to enhance the integrated care needs of African Americans with mental illnesses who are homeless. Dr. Corrigan is a prolific researcher, having authored or edited 12 books and more than 300 papers. He's an editor of the American Journal of Psychiatric Rehabilitation. Today, Dr. Corrigan will discuss the competing perspectives on challenging the stigma of mental health illness. Welcome, Dr. Corrigan. And I will pass the screen over to you.
Okay. So you can see the slides?
Yep.
Good. Thank you, Emma. Thank you all for joining us. What I wanted to do in the next 40 or 45 minutes is look at the issue, the stigma of mental illness, and more importantly, how to impact it and how the whole new area of integrated care might change this picture. The slides are not going forward. Oop. There we go. So we all know what stigma is. Stigma is a disrespectful, heinous view of people with mental illness, showing them as dangerous or unpredictable, or in some ways likely to hurt people and be violent. And we all know what the goal is. The goal is to try to stop stigma. What we've become interested in is what are effective ways to stop stigma, and equally important, what are some unintended consequences of ways to change stigma. One of the things that's become interest to us is the Dodo Bird, and what you see in front of you is a Dodo Bird who's from Alice in Wonderland. In Alice in Wonderland, the Dodo Bird hosted a race, and at the end of the race concluded, everybody's won, and so all must have prizes, which in social science is a bit of a problem, because it sort of leads to the idea that if everything works, you don't know what to do. And so we're at the point now in the research on stigma and stigma change to realize not everything works. In fact, some things lead to unintended consequences. You know, there's a good example of unintended consequences when Pope Francis, who was Cardinal Bergoglio from Argentina, was inaugurated March 19, 2013. He named himself after St. Francis of Assisi, and in his inaugural mass, he talked about a need for the church to turn towards the poor and the weak, in some ways echoing the New Testament, whatsoever you do to the least of my brothers, that you do unto me. Here's the unintended consequence of what he said. He also went one step further and said we should focus on the least important. And in the perspective, what we do is we elevate people with special needs into the least important and elevate the rest of the world into bestowing upon them charitable alms, as opposed to empowering them and give them the opportunity to obtain what is rightfully theirs. And that's the stigma picture, is we don't want to view people with mental illness as one down and sort of grant them charity. We want to empower them and give them what is due. And so what I want to do in the next 40 minutes together is look at stigma. Stigma is easy. We all know it's bad. We distinguish between public stigma and self-stigma, and the idea of not all ways to address stigma work. And then leave some time in the process to talk about how integrated care might be a special circumstance for stigma and stigma change, reminding us that as we pursue this, what we need to do is look for the data in terms of how stigma varies in integrated care, whether it's less impacted and the like. As Emma said, I'm the PI of the National Consortium on Stigma and Empowerment. Our web address is ncsc1.org. More importantly, is I sincerely like to dive into stigma issues. If anybody would like to follow up with me, my email address is corrigan@iit.edu. Emma also suggested that our center is working in integrated care. We have a grant on peer navigators in integrated care from the National Institute of Minority Health and Health Disparities. We're also the home of Together for Health, which is a coalition of 34 clinics in Chicago representing Illinois' response to the Affordable Care Act and Medicaid expansion. So that's my background. What is stigma? A sociologist named Sam Keene wrote a book called Faces of the Enemy, and in this book he looked at how groups in power through history have demonized and kept minority groups down in the media. And perhaps one of the worst examples in American history is the way the white majority portrayed African Americans. In this case, scientists say Negroes still in ape stage. Several egregious, horrible things of this. I put it here because it reminds us in 1 second exactly what the hurtful nature of stigma and prejudice are. and the stigma of mental illness is in the same category. Equally sobering is that this came from an 1890s medical textbook. And so we had scientists perpetuating stigmatizing images. You see it here in the way we show certain groups as animals. This is from World War II Denmark, in which we show Jews as rats. And here, what one half of the population has been doing to the other half of the population for centuries. So the harder a wife works, the cuter she looks. If there's any good news, and there's rarely good news about racism and sexism and the like, the public manifestation of it is more or less gone away. I mean, you would have seen images, disrespectful images of Kellogg's Pep cereal and women in my lifetime, and you pretty much won't see that kind of thing anymore. Not so with mental illness. I mean, all you need to do to hear the stigma of mental illness is on the way home tonight, listen to talk radio, and the amount of times people talk about psychos, wackos, and nuts. You see people with mental illness represented as dangerous. You see them in Freddy Krueger, Nightmare on Elm Street, the worst cinematic maniac since Darth Vader, or Jason, Friday the 13th, Part 3. You see it in the newspapers, freed mental patient, kills mom, or get the violent crazies off of our streets. Now, the problem with newspapers is there's supposed to be some credible evidence in the world. It's supposed to drive us towards thinking this is the way the world really is. I mean, to be honest, these are tabloids, and anybody who stood in line in a grocery store knows this is the kind of hateful thing tabloids do. But this is examples from The Reader. The Reader is a Chicago weekly, very well done, very well respected. In this story, the gentleman on the left had the horrible misfortune of killing his wife in a drug-induced psychosis. He was a physician, ended up spending more than a decade in the forensic unit outside Chicago, the mental health prison, as it were, was ready to be returned, and the author, Ted Klein, wrote a pretty balanced summary of what happened, but it was the editor who slapped this headline on, "Is this man a monster?" And as a result, amongst many things, the gentleman's return to his community was detoured by years. You see in advertising, this offer could get you committed. Crazy Eddie's Record Asylum. To offer these deals, you'd have to be committed. Maniac out of control. Or lobster lunacy. This was a billboard outside Washington, D.C. for many years. Now, sometimes people might think, shouldn't you just lighten up a little bit? I mean, is this a bit political correctness? But then again, we might have said that about women. The chef does everything but cook. That's what wives are for. Just as we realize now that Madison Avenue is terribly wrong to try to sell products on the back of foolish images of women, so similar with trying to sell products on mental illness. This is particularly telling. This won the Clio Award, which is the equivalent of the Academy Awards in advertising several years back. It's a straitjacket filled with nuts. You see it in the comics. Now, I have to admit, I'm a big fan of Gary Larson, but there's several things wrong with this comic. In part, just the disrespectful way the guy in a chair is referring to the guy on the couch, but even more, we recognize a guy in a chair as a psychiatrist, and if it's okay for a psychiatrist to laugh at the patient, it must be okay for anybody to. Or this, sir, these gentlemen from the U.S. Equal Employment Opportunity Commission are here to explain new rules on mental illness in the workplace. You want to know what's really interesting about this is when George Herbert Walker Bush, the first George Bush, signed the Americans with Disabilities Act, it was in place for 5 years before anybody ever thought it applied to psychiatric disabilities. The EEOC in 1995 said, lo and behold, it does apply, and you saw a slew of ads making fun of trying to use the ADA in workplaces. Or this, S is for Stanley. Stanley's a crazy murderer who likes to murder little boys and girls early Sunday morning. Are you afraid of Stanley? What's particularly telling about this is it comes from a Michelle Silverstein book. Many of you with parents with children probably read books like this to your kids. This is from his dictionary, his A to Z dictionary. Part of what I've been showing you is what's considered the worst stigma, that people with mental illness are violent and unpredictable, but there are other stigmas. One of them is benevolent stigma. It's hard to think stigma could be benevolent, but it's the idea that people with mental illness are big, lovable children. And what they do is they need an expert like me, like a professional, to tell them what to do. And so you see it in movies like The Dream Team. This is Christopher Lloyd, Peter Boyle, Michael Keaton. They're for psych patients who get away from their keeper and have this zany, wacky day popping around Manhattan because that's, after all, what psych patients do. Or this, Me, Myself, and Irene with Jim Carrey. What some of you might know is Jim Carrey actually has bipolar disorder. And so when this was coming out, people sort of urged him to tone it down a little bit. But at the time, he didn't quite recognize the significance of the stigma in this image. How to avoid hiring lemons, nuts, and flakes. What's particularly concerned about this is that it was developed by a human resource department. So the group that are responsible for protecting rights on the job site and undermining stigma were perpetuating it in images like this. Is it any better? Well, let me give you some examples. To understand this picture, it's from downstate Ohio. It's from a few years back. Pretend the woman's not there for a minute. What you see is a kicked over stool, two legs hanging down, and a sign saying contemplating suicide. Get your suicide notes printed here, because this is a printing company. If that's not bad enough, she's the owner of the company. When people tried to explain to her why this was a problem, she turned over her hands and said, "What's the big deal?" Or another example is in 2002, Trenton State Hospital. Many of you probably know Trenton State Hospital. It's where John Nash, the Nobel laureate from Princeton, would go when he would relapse. They had a fire. Nobody was hurt but did some damage. And the next day, the local Trentonian's headlines was roasted nuts. So the stigma of mental illness is still pretty evident, at least from individual examples. What does research show? Well, colleagues of mine, Joe Phelan and Bruce Link, did a study looking at the degree to which the American population views people with mental illness as dangerous, looking at 1956 versus 1996. And what you might hope is perhaps in 1956, about 40% of the population would view people with mental illness, and in 1996 it would cut in half to 20%. The data is actually the reverse. Is across those 40 years, twice the population have endorsed the idea that people with mental illness are dangerous. Now, a couple things to think about this. 40% is no small amount. I mean, we're talking about in a group of 10 people, 4 people think people with mental illness are dangerous. And here's the problem with thinking they're dangerous, is you're going to avoid them. You're going to want to hire them, not want to live next to them, not want to be with them at church or your faith-based community. 1996 is a bit of a time ago. They repeated it in 2006, and the bad news, there's really no change over that time. So the stigma of mental illness is really still pretty prevalent. So we know what the goal is. We want to stop the stigma. What about changing it? What are some of the unintended consequences? Well, let's talk about some of the easy stuff. What I frequently hear in conferences, if we just change the words or just cure the disease, the stigma will go away. And so what you find is leprosy is now called Hansen's disease, dementia is called Alzheimer's, mental retardation is intellectual disability, mania is bipolar illness. Actually, Japan unintentionally provided an opportunity to do a study on what happens when you change names. In Japan, up to about 3 years ago, they referred to schizophrenia seishin banetsu, which is translated as mind split disease, which in Japan is considered a pretty stigmatizing term. They changed it to Togo Shitko Sho, which is integration disorder, which is hopefully, which was less stigmatizing in their culture and hopefully would lead to decreased discrimination. This actually provided an opportunity for research. They did several studies, including by Takashi, published in 2009 and 2011, which found a couple things. One is you did find that psychiatrists in Japan were aware of the name change, in part because, like in the United States, if you're going to bill for mental health care, you better know what the diagnosis is in the DSM-5. But the other thing you found is that it had absolutely no impact on the public. Public stigma didn't change. The public really was kind of oblivious to the name change. But even another example is Hansen's disease. I had to admit before I started working with Wim van Brakel, who's in Amsterdam, I thought leprosy was gone. Leprosy, unfortunately, is still a very prominent illness, especially the equatorial countries low on the income scale. What you found in those countries is that whether you call it Hansen's disease or leprosy, the stigma is still quite prominent. But putting that aside, the other thing to keep in mind about words is whether you call it schizophrenia or something else, whatever you call a group of people and label a group of people, it perpetuates the difference. We might think, for example, that no longer using the N-word and now saying African Americans has greatly decreased discrimination and prejudice towards that group. And in some ways, perhaps it is, but we also know that when you change words, racism becomes what's called modern racism, which is that the population no longer goes around endorsing these horrid words, but racism still is quite prominent. Modern racism is just under wraps. And so similarly, if we stop calling it schizophrenia, the fear of people with a new label is still going to be pretty prevalent. What does this have to say for integrated care? Is calling behavioral health like physical health, is it calling an illness like any other illness? Well, there's an interesting issue here. One, for me, it's an empirical issue, which folks on the phone may want to someday study, which is the idea of difference. Are we diminishing the difference because they get sick like everyone else, so people with schizophrenia are similarly sick like people with respiratory infections? Or is it still perpetuating the idea that sick is sick and you're still broken? And so still having labels of mental illness, even in an integrated care setting, will perpetuate the stigma. Another unintended consequence, to understand stigma change a bit more, this is a model we've come up with for understanding how to fix stigma. We've looked at the idea of, well, let's go across the top row, protest, education, and contact. Protest is a shame on you. I'm sorry. Let's talk about education for a minute. One of the ways you frequently hear people talk about erasing the stigma of mental illness is to educate it away, the idea that knowledge is gold. And so looking at education, 1990, the National Institute of Mental Health started the Decade of the Brain. And the purpose of the Decade of the Brain was first to increase funding for mental illnesses, the brain disorders, but second, there's hopefully an anti-stigma view of it. Because if we taught the population that mental illness is a brain disorder, then perhaps we blame them less for their illness. And lo and behold, that's what research shows. It's showing brains lit up as an explanation of mental illness decreases the blame. But the other problem with it is it also decreases the idea that they're going to recover. It sort of leads to the thought that mental illness is hardwired in, that their computer is broken, and regardless of whether they're blamed for the mental illness or not, they're not going to get any better. And the concern about recovery is that's what leads to discrimination. If I believe people aren't going to recover and I'm an employer, I'm not going to hire them, and I'm a landlord, I'm not going to rent to them, and if I'm a primary care provider, I'm going to provide a worse standard of care. This has been a big debatable issue, is if we improve knowledge, will stigma decrease? And so we, with the colleagues in Germany, did a meta-analysis, and a meta-analysis statistical procedure by which you collapse findings across, in this case, 16 different studies. And we were interested to find out over the course of time whether knowledge about mental illness has changed, and if so, whether stigma has changed. And what you found is that from 1990 to 2006, you find these kind of trends. The red line is the public's view about schizophrenia. The brown line is the public's view about depression. In the course of those 16 years, the belief that schizophrenia is inherited or genetic has gone up significantly, almost by 20 points. Similarly, the belief that depression is genetic has gone up by a similar amount of 20 points. During this time, also, you see that the degree to which the population views serious mental illness as a brain disease has gone up notably during that time, as has depression. So the good news from an education viewpoint is that there's more support of the idea of mental illness being a brain disease. The bad news is what kind of impact it has on stigma. Acceptance of mental illness, accepting people, the coworker, you see two things. One is over 16 years, you see no change in depression, which is quite contrary to what people say anecdotally. People say anecdotally the stigma of depression has gone away because antidepressants are so popular, not what you find here. The second thing you find is the stigma of schizophrenia, consistent with Joe Phelan, has gotten worse. You see that in acceptance of coworkers, and you see that in acceptance of neighbors. Another question is about protest. Another way to change stigma is to appeal to to show disrespectful images of people with mental illness, and then sort of say shame on us for thinking that way. So in the research we've done, we would show people slides like this, get the violent crazies off of our streets, and then an appeal of this is morally, ethically, somehow socially wrong. We should stop thinking this kind of thing. The problem with suppressing thoughts that leads to the rebound effect, and in social psychology, you frequently find the rebound effect in the white bear study. For the next 2 minutes, I want everybody on the phone not to think about white bears. And what happens is we tell people not to think things, attitudes about their group get worse. And so similarly, telling people not to think bad things about mental illness can actually make attitudes worse. That said, protest clearly has a function for changing behaviors, especially marketing behaviors. Some of you may recognize this show called Wonderland, which ABC ran in 2000. It was about a forensics hospital in Manhattan. In the first episode, a person with mental illness on the left shot at 5 police officers and stabbed the pregnant psychiatrist in the belly with a hypodermic needle. Needless to say, advocates like Stigma Busters are very concerned about this, got together, and the long and the short of it is convinced ABC to pull it off after they convinced their sponsors that they weren't going to buy their products as long as they continue this kind of representation. That said, though, here's an interesting example of unintended consequences. I believe many of you are in California. You might know about a chain of stores out there called Psycho Donuts. They originally opened up in Campbell and San Jose, California. They sell products like the Jason Nut, the Suicide Squeeze, the Crazy Face, obviously disrespecting mental illness, trying to sell their products in the back of horrid images of them. Again, groups like Stigma Busters decided to come up with a campaign to get Psycho Donuts to turn it down. They said join the national online food fight by turning lemon donuts into lemonade. Personally a little cute for me, but still the message was that we need to quit disrespecting mental illness. This is an interesting example of a rebound effect because people like Stan Rezi from a local newspaper and Examiner.com said, I'm an advocate of equal rights and a more tolerant world towards people of different races, religion, gender, and sexual orientation, but that's it. Anything else is just moronic. Some people turn this around into a civil rights issue. And the result of that is that Psycho Donuts has gone franchise. If you Google Psycho Donuts, you can actually buy the franchise and open one up near you. So talk about a rebound. It seems to have taken off as an example. What I would promote as a way of changing stigma is contact. And so what is the relative value of contact versus education? Education, again, is reviewing the myths versus the facts of mental illness. Contact is opportunities to have people with mental illness come out, as it were, and tell their story. In the research we've done, we partner with a friend and colleague of mine named Bob Lundeen. Bob is a person with schizoaffective disorder. When he tells his story, he says that for him, his childhood was not unusual. He's trying to challenge the common stigma that people with mental illness are born broken, that unfortunately his mental illness is traumatic, that it's much more than test anxiety, that it's got him hospitalized, that he's tried to kill himself, he's abused drugs, he gets in trouble with the police. He still gets hospitalized. But despite that, he's achieved several accomplishments. He works full-time. He and I worked at the University of Chicago together for several years. He now works as a peer counselor in DuPage County, just west of Chicago. He has a condo. He has significant others. He travels. The very exciting thing in the last few years, become a published playwright, and despite that, stigma has a big impact. And so by this time, there's been a lot of research looking at the impact of contact versus education. And so we did a meta-analysis published last year looking at 79 studies conducted on 38,000 people on what the overall effect of contact versus education is on the overall effect on attitudes and on behavior. This is the result just from the randomized controlled trials. The red bars are contact, the blue bars are education. what you can clearly see is huge differences in the effect of contact over education, almost 2 to 3-fold differences. So clearly contact is the way to go. These are pre-post differences. We also coded for follow-up effects, whether or not seeing a contact versus education maintained effects weeks or months later. We did report this in the meta-analysis because there were only 2 studies that ever did it, one by us, and what we found is any positive effects to education went away as follow-up, whereas effects of contact were still fairly robust. So there's issues of looking at impact. If you're going to do contact, do you do it in the media or you do it in vivo, face-to-face? So what are the promises and limitations of social marketing? SAMHSA, the Substance Abuse and Mental Health Services Administration, has done a fair share of social marketing, frequently public service announcements and corresponding campaigns. Perhaps a better known one is the one Glenn Close did in Bring Change to Mind. In this case, they showed pairs of people. The gentleman on the left does, in fact, have PTSD from duty in Afghanistan. The woman on the right is a friend of his. Also, I found out later, a 3-star general. And the idea of pairing up people with illness and a peer. The military's gone one further. This is Real Warriors, done by the Department of Defense. This is MakeTheConnection.net, done by the Veterans Administration. But let's go back to the SAMHSA one and say, what kind of impact does it have on people? The interesting thing is you want to look at 2 things when you're trying to understand the impact of public service announcements. One is penetration. Penetration is if I came up with a new dancing Coca-Cola can, penetration would be the degree to which people in the public remember seeing it. And so the What a Difference a Friend Makes rolled out in March 2008. About 30% remembered seeing it, which is actually a pretty huge impact. A year later, it was still around 28%. So it seems to be penetrating the market. But the second question is, just because people are seeing it, is it impacting them? And one way to look at impacting is most of the public service announcements have a website. Like this is the website for What a Difference a Friend Makes. Again, by SAMHSA, you can go to it, learn more information about mental illness. They typically have hot buttons for suicide prevention, so a person can right there get help if they need it. What kind of impact does it have? Well, people did research on a similar public service campaign. They found out between time 1 and time 2, the number of visits to the website went up from about 2,000 to 8,000, which if there are any statisticians on the phone, which is an odds ratio of 2.81, which is to die for. That's huge effect. You can see it's almost a 4-time effect. But here's another way to look at it, something called effect size, is aspirin decreases the headache, but does it really decrease headache in the real world? Or in other words, how many people in the real world did this public service announcement impact? If you see down in the lower left-hand corner, you see thousands. To put this in perspective, this campaign was shown to more than 38 million people, and only thousands went to the website, which isn't a very big impact. And of those who did go to the website, about 88% left after 1 minute. Now, marketing consultants will tell you that's very typical when people surf, but perhaps it is, but if you're really trying to change attitudes about mental illness, I'm not sure being in a minute is going to make any differences. Something to keep in mind about the media is the possibilities of the population. I mean, the good thing about public service announcements is that we're a huge country. The last census said about 300 million people. On top of that, you go from Augusta, Maine out to Honolulu, Hawaii, and you're going thousands and thousands of miles, and so the media has huge potential for impacting lots of people. On the downside to be concerned about the media is that it may be taking stigma change out of the grassroots hands. And one way to look at that is that civil rights change occurred at the local level in the community itself. Now, perhaps if at the time we had Facebook and better social marketing, changing African American rights might have decreased, but still, you got to think a lot of the power of civil rights occurred because of grassroots influence, and so some of the concern about social media and public service announcements were putting stuff in the hands of Madison Avenue as opposed to people with lived experience. That keeping in mind, though, media is changing really fast. A Pew Research Center report let out this year is in terms of text, is 63% of kids, of youth, of teenagers are getting about 60 texts a day. Compare that to about 39% on the phone and 35% of face-to-face. And so while I believe contact is a good thing, and I believe face-to-face contact is a good thing, by no means can we dismiss the importance of media and the new media and the age as the demographic changes. So I've shared with you what are some of my concerns about stigma change. This is what we would promote as one of the more effective ways of actually impacting it. This is developed through support with Cal Mesa and the Center on Dignity, Recovery, and Empowerment out of the Mental Health Association of San Francisco. It's a model that we think effective stigma change is targeted, local, credible, continuous contact. So you notice the whole thing rests on contact. And so the whole thing is put in the hands of people with lived experience. Who should the targets be? You know, I would love to change public attitudes about mental illness. You know, I'd love to change public attitudes about race. But at the end of the day, advocates will say, well, it'd be nice for people to like me. I don't want people to discriminate against me. And so you need to target stigma change for landlords. So you make sure landlords are providing full opportunities for rent and support in rental property. Employers, so they're hiring and providing reasonable accommodations. Healthcare professionals. What I didn't share with you is this pretty compelling research that if you're a person with mental illness going to a primary care doc and the primary care physician finds out you have a mental illness, you're half as likely to be referred for secondary care. What is local? When we've rolled out this model, we did it in Canada, and what Canadians will tell you is that things in the United States don't play very well in Canada. But even that said, I'm calling from Chicago. For those of you who don't know Chicago very well, we're up there in the upper right-hand corner on Lake Michigan. Chicago is extremely metropolitan area to which the rest of the state, which is agrarian, cannot understand us or really like us for that much. There is a slogan, pretty popular in the United States, does it play in Peoria? And so if you're going to develop a program for Peorians, you better make sure it represents the local interest of Peorians. That said, though, you also want to frame things for city versus suburban versus rural. Perhaps things play out different ways in offices or churches or synagogues. Related to that is the idea of credible. Who has the most credibility in the ethnic community is probably people from that ethnic community. So programs that are developed for people, for African Americans, should mostly come from African Americans. People from Asians, from individual Asian communities. We've done some work with the military, and we found out pretty quickly in looking at the military that credibility or other military, either current or ex-military. And that said, Army talks to Army, Navy talks to Navy, Marines are tougher than everybody else. And even within that, you have to look at the impact of enlisted personnel versus officers in terms of the message. Continuous, we found out that once is not enough. I mean, meeting Bob Lundin one time has an impact, meeting him multiple times has a bigger impact. So that's led to what we believe is the grand plan of stigma change, that what we believe is that people come out with their mental illness, they will have a huge effect in changing people's attitudes. That if people come out mad and they come out proud, that they're a living witness that mental illness is a lot more than the prejudice and discrimination. And so that said, we developed a program called the Coming Out Proud program, which is meant to change old notions in the provider community about being a mental patient. When I was worked in a medical school, I learned that you want to tell people not to adopt the disease identity. They want to get as far away from their illness as possible, perhaps put it in the closet. And what we realized instead is that people with serious mental illness, for some people with serious mental illness, it is part of their human identity. And just as being gay or being black or being a woman is part of one's identity and need to be embraced, so the same thing with mental illness. I guess the question is pride a fair term here? I mean, is it the number one goal of being mentally ill to get out of the group? We would argue that overcoming the disability is a huge accomplishment for people, something to be proud of. Even if their symptoms don't go away entirely, the notion of recovery is being able to live with what you got and being able to act in the world. Similarly, it's also who people are. I mean, I'm Irish American. I've never done anything to earn being Irish American, but it's part of my identity. And similarly, many people with serious mental illness is part of their identity, and they need to come out and talk about it. It's an issue of being authentic. And so coming out has 3 lessons. It's a program run by people with serious mental illness for their peers. And the first lesson is consider the pros and cons of disclosing. Next is whether there are different ways to disclose. And finally, to tell your story. With Cal Mesa's support, we're actually doing a randomized controlled trial throughout California on this now. We've trained 16 trainers in the northern half of the state and going to repeat it in LA soon. We did a study in Switzerland and showed that this led to significant change. You know, I'm a clinical psychologist and a rehab researcher, and so when I do that kind of work, my constituency are people, are service providers. When I do research on stigma, my constituency are the advocates. Perhaps one of the most esteemed advocates in American history is Martin Luther King, who taught us how to be upfront and out in terms of dealing with the stigma of race. There are similar heroes in mental health. Clifford Beers, who started out, who is the founder of what is now Mental Health America, was in state hospital for several years. When he was released, he came out and said he must fight in the open. And so he reminded us that being out in front is central to being successful. And so let me stop there. Again, our website, and open it up to questions or comments or any thoughts about what I just said.
Great, thank you very much, Dr. Corrigan. So if you have any questions, you can submit them through the chat feature on the GoToWebinar control panel under questions. So the first question is, has there been any research on the impact of protest strategies directed at media outlets and the subsequent flow of stigmatizing content from those outlets?
Has there been any research on it? So it's a very hard thing to research because it's a very hard thing to manipulate. What we have found is we did a study, came out about 6 years ago, where we had research assistants review the everything that was published in the news media in a previous week, and we found out about 60% of the time news media were perpetuating ideas that people with mental illness were dangerous. So that's 5 years old, but there still was this idea that mental illness and danger was out there. In the rest of the population, its impact on media, I don't know. I would suggest, though, that if you're going to use protest, media outlets would be the way to do it. If you're going to go to Rotary, and by the way, I think Rotary is a great group to try to change public stigma because it's a ready-made collection of community leaders. If you're going to go to Rotary, protest is absolutely not the way to go. I mean, you don't want to go in there and say, shame on you for thinking that way. You want to do some sort of contact.
Okay, thank you. The next question is, as practitioners, what can we do on a daily basis to help reduce stigma?
So I run a center on adherence and self-determination. We chose the word adherence because the National Institutes of Health like the idea of adherence and think if patients are good patients, they should do what they're supposed to do. But we actually think a more informed and something that holds up better with research is self-determination. And so as practitioners, I think the first way to deal with stigma is to remember that like anybody, like your patient with a respiratory disease, your patient with mental illness has total right to determine what he or she wants to do for their treatment, which is very central to the integrated care studies we have going here in Chicago. It also means, by the way, being prepared for people to make decisions that I'm not particularly happy with, but that's the nature of providing services.
Okay, you had mentioned some international research. Are there any cultures that we should learn from in regarding how they present mental illnesses or treat mental health?
So we did a study in China. It was funded by the Institute of Mental Health, and we looked at stigma in employers in Hong Kong, Beijing, and Chicago. And I bring that up because employers, this was a representative sample, so it was a population sample. Employers in Beijing were more stigmatizing than they were here. So what you frequently hear is generally Asians are more stigmatizing. That said, I have two thoughts to that. First is perhaps, but if you're an American, a European American, you just get turned down from a job because the person thinks you're mentally ill, you can't deny the impact of discrimination. Second thing is what's a recurring finding in the research literature, which is hard to make sense of, is while schizophrenia is the same throughout the world, it's about 1% of the population. It's about 1% of the population in India, in the United States, in Mexico, everywhere. The course of schizophrenia, that is the nature of the symptoms and disabilities, is usually more benign in what we're called third world nations, in developing nations, in Asian nations. So I think the take-home message is, like anything in cultural diversity, we shouldn't assume that any group by nature of being in that group is more or less stigmatizing anybody else. We should also assume, and what Cal Mesa is doing very nicely, is that anti-stigma programs need to be developed by the community. So as you know, in California, there are areas that have large Hmong populations, and so Cal Mesa is sponsoring research trying to develop programs that address Hmong's biases towards people with mental illness.
Thank you, Dr. Corrigan. We have a few more minutes, so if there's any other questions, please feel free to submit through the chat feature. So thank you all for participating today. If you could please take a moment at the end of the webinar to complete the evaluation, we would really appreciate that. The webinar recording will be posted on our YouTube channel, which is youtube.com/CUDFM policy channel. And I hope you all can join us for our December webinar, which will be integration in pediatrics. Thank you very much and have a good day.